Thank you very much. Good morning, good afternoon. The hand clapping was very small compared to Prof's own. And Dr. Iseko decided to ambush me after Prof's presentation. I don't even know how to get to the foot of his presentation, but I'll try my best. My name is Dr. Aghanya Nonso. Fortunately, I'm an endocrinologist, I'm a cardiologist. So I want to take you away from hypertension, cardiac, ECG, ABG, PDP, APC. Let's go to something different. I was privileged to train under Prof. Then I was a resident in Gombe. He was visiting us and he did so many things to us then, but actually paved way for us to where we are now. Thank you very much, Prof. Yeah, so IT, let me beg you, please. Okay. I'm begging you. So we're talking about diabetes. Diabetes today is a very, very common metabolic clinical condition that we experience in our practice. I'm sure it might be more than hypertension, but I'll give you my own facts. Patients are always coming in with complaints of polyuria, polydipsia. I'm sure I can use those terms here. Polyuria, polydipsia, weight loss, and most times doctors are scared. I don't know if it's because of insulin. I don't know. To start patients on insulin. But today, I'm very sure I'm going to demystify that insulin approach so that our patients will do very, very well. So, let's start with this first case. There won't be time for that long. How much do you have? So, that long, this thing will not come up. So, in your mind, as you are going, be correcting yourself. So, a 42-year-old new employed office executive, while undergoing routine office medical checkup, I used office executive, found to have a fasting plasma glucose of 9.0 millimoles per liter and a blood pressure of 110/80. No other presenting symptoms. Otherwise, patient is stable. Yeah. So the question I got up there for 2-year-old employed office executive did a routine office medical check. The fasting plasma glucose was 9.0 millimoles per liter. BP was normal, no other presenting symptoms. So the question is, do you think this patient is diabetic? Assuming it was, I heard yes. Let me finish the question first. Assuming it was in your clinic, they brought this patient and they did, in Nigeria, to be honest, issue of diabetes, we health workers are battling so much with patent medicine store people. They do RBS, they do fasting, they mix all sorts of things. So it's really, really a big issue. I'll come to that. So, do you think the patient is diabetic? Yes, no. It depends, and I don't know. It depends. Okay, I'm not doing a polo. Have it in your mind. We'll come to that. So, how will you diagnose? How will you make a diagnosis of diabetes in this patient? Are you going to repeat the fasting blood sugar? Are you going to do oral glucose tolerance tests? Are you going to do HbA1c? All of the above. My brother, you see me for dream. So, timekeeper. Hope you are. There's VR there, you know. So, will you repeat? Do you do OGTT? Do you do HbA1c? All of the above? That's the first question. Is there any other history you want to take from this patient? An executive director that came for. Please have your answers in your mind. We'll continue. So, by way of definition, diabetes is a heterogeneous endocrine metabolic disorder. Heterogeneous mean, even the calories we are calling hormones or prophets here, sorry. So, as I was saying, it's a heterogeneous endocrine disorder of metabolic in nature, affecting mainly carbohydrates, fats, and protein, not only carbohydrates, but is characterized by hyperglycemia due to relative or absolute insulin deficiency associated with long-term complications. So what this thing means is that diabetic patients have a problem of insulin. This insulin can be in the form of absolute deficiency, like you see in type 1. It can be relative deficiency, like you see in insulin resistance of type 2. But now, it has been found that even the type 2, towards the end, they can have absolute insulin deficiency when the beta cell has been exhausted. Patients coming down with no insulin at all. Now, epidemiologically, diabetes is found in every population in the world and in all regions, including rural and middle income countries. It used to be disease of the rich, but now even the poor and the poorest are suffering from diabetes. The number of people with diabetes is steadily increasing, with WHO estimating that we have 422 million adults with diabetes as of 2014. Now, the age-adjusted prevalence in adults rose from 4.7 in 1980 and 8.5 in 2014. Greatest rise in low and middle income countries compared to high income countries. I think you understand. The trend is changing now from the whole rich countries to middle income country. But I don't know where Nigeria belongs. Is it low or middle? It's for you to decide. So in addition, the International Diabetes Federation estimates that 1.1 million children and adolescents aged 1 to 4 have type 1 DM. Now, without intervention to halt the increase in diabetes, there will be at least 629 million people living with diabetes by 2045. I'm very sure all of us here will reach 2045. So by that time, 629 million people, I don't know who will be part of it by that time. High blood glucose causes almost 4 million deaths each year whole wide world. But the beauty of it is controlled blood glucose does not cause death. It is those that don't have good control that fall into this category. IDF estimation estimates that annual global healthcare spending on diabetes among adults were 850 billion US dollars as of 2017. That was some years ago. So you can imagine what it is now. In 2021, the prevalence was found to be 3.7 in Nigeria, as according to IDF. But studies done by Professor Loco et al. Tried to pull the prevalence in the 6 political zones. So from this, you know where you belong. 3.0% in the northwest, 5.9 northeast, 3.8 north central. I mean, it's Abuja. I don't believe so. 5.5 southwest, 4.9 southeast, and 9.8. South. Dr. Dafe. South. 9.8%. So now, and from undisclosed sources, it was found out in Nigeria that 2 out of every 10 Nigerians is diabetic. Meaning that 1 out of every 5 is diabetic. So now, in classifying diabetes, it keeps on changing. When we were in medical school, we had 4 types: type 1, type 2, type 3, and type 4, which we call the gestational diabetes. So, but now, I have to give you the current trend now. As of 2019, if you left school before 2019, this is the new category of diabetes we have now. We have type 1, we have the type 2, we have the hybrid forms of diabetes, which included slowly evolving immune-mediated diabetes of adults, what we call LADA before, or type 1.5. Ketosis-prone type 2 diabetes, known as flatbush diabetes. Now, the former type 3 now is now type 4. Other specific types, which include monogenic diabetes of beta cell function, the MODY 1, 2, 3, 4 to 9. We have the defect in insulin action, hypertonism, and cerebral disease. Disease of exocrine pancreas, which includes pancreatitis, pancreectomy, endocrine disorders, thyroid disease, other growth hormone abnormalities, steroid synthesis dysfunction. Then drug-induced, like all these anti-hypertensive you take, AC inhibitors, thiazides, they can also cause diabetes. Infections, uncommon specific immune mediator, Down syndrome, other genetic diseases. They have the unclassified. Now, that is to tell you that diagnosing diabetes is even very difficult. WHO couldn't find a particular group and created one group called unclassified. I'll look at what they wrote. This category should be used temporarily when there is not a clear diagnostic category, especially close to the time of diagnosing diabetes. So you can send a referral to Limi Clinic and put it unclassified if you are not sure. We'll now take it from there. The WHO also said it. Now, hyperglycemia first detected in pregnancy. Before it used to be gestational diabetes, but now they have to bring in patients that were diabetic before getting pregnant. We used to call them pre-gestational diabetes, but we call it diabetes in pregnancy and gestational diabetes. So, pathogenesis, I just mentioned one or two things because the main thing is the management. Type 1 is always immune-mediated, like we all know, and it has HLA predilection. At the same time, what again? As autoimmunity, we have anti-GAD, islet insulin antibodies, anti-islet cell antibodies. These are found in type 1 patients. The environmental factors also contribute to type 1, development of type 1, which includes congenital rubella, CMV, bovine milk. All these things come about what we call molecular mimicry. When antibodies that are directed to all these ailments like rubella, CMV, and bovine milk, those that give children, babies, tin milk, you understand? It contains what we call casein. That casein has the same molecular arrangement with GAD, acid decarboxylase. Now, antibodies come, instead of to attack the bovine, at the same time, they'll be attacking the GAD. We call it molecular mimicry. At the same time, we can what we call bystander effect, whereby the pancreas is on its own, autoimmune diseases that are doing something else will come and destroy and involve the pancreas. We call that one bystander effect. These are the methods of type 1 DM. Then for type 2, there is serious genetic predisposition, what we call family history of diabetes, which is very, very significant in these patients. But I would like to tell my patient that family history, what it does is just to load the gun for you. Lifestyle is going to pull the trigger. If you have a family history of diabetes, father, mother, and you decide to be drinking with 5 cubes of sugar, no exercise, drinking mineral malt, you don't go for any jogging, nothing. You move from AC car, AC office, AC house. Inside the house, you use remote control. I call it posh living. My brother and sister will come back to us. So please, family history only predisposes you to diabetes. Lifestyle is what directs where you go to. You understand? You cannot buy a Mercedes Benz and be carrying firewood. It's not possible now. So it's not possible. So environmental factor, low birth weight is very, very important because we call it the thrifty gene hypothesis, where a child has not been exposed to enough, born with low birth weight. Fortunately, if there's something for him to eat or her to eat, he now overeats, gets obese, and gets predisposed to having diabetes. Obesity, losing of weight, sedentary lifestyle, aging, then insulin resistant, pre-diabetes, and all those ones. Risk factors for type 2. Now, why I'm emphasizing on type 2, most times, type 2 is much commoner than type 1 in the environment. And most times when these patients come, I want to give you a clue, and they're between the 20s, 20 something, or 30, there's usually a history of they've been treating him with metformin and Dianyl, no improvement in the past 3 months. Please suspect type 1 in that patient. Because what this drug does is to increase insulin secretion and increase sensitivity. But in type 1 patients, unfortunately, there's no insulin production, so these drugs don't even work. So when you have a patient that have been managing with glucophage, Dianyl, I'm not quoting any brand, but what I'm saying is normal thing patient tell you. I'm glucophage and Dianyl, and there's no improvement. Please suspect type 1. And in type 1, family history is very, very low. So type 2 is common in the environment, very common. I'm sure if I do a random blood glucose here, I'll pick something. But we're not doing anything, no, please. And thank God they're eating something, so everybody will be alert. So risk factors for type 2, family history of diabetes, like I said, this has percentages. But not because your father is a witch, he must be a witch. No, you have to choose your own path. But if you decide to play around the witches, they will bring you close. That is the basic thing here. Obesity. They call it living large. You are doing well. You are going down. Habitual physical inactivity, I talked about. Posh cars coming down. You know, it's so bad that if you park your car, say, let me even walk. Doctor, is anything wrong with your car? You know. That's how bad this country is. Nothing. I want to walk. Walk the walk. Race, ethnicity, previously identified impaired fasting glucose, history of GDM, these patients, hypertension, HDL cholesterol, triglycerides, very, very important. Triglycerides causes pancreatitis, so it can also cause type 4 diabetes. Polycystic ovarian syndrome, then history of vascular diseases. Clinical features, they can be asymptomatic. These patients can present in A&E, unconscious. They can come for routine investigation. It's an RBS of 21. So it's not a matter of I'm rating every time. No, it might just be looking okay. The blood glucose is very, very, very high. So I want to encourage everybody, anywhere you walk, please, if a patient comes in, do a routine. It's not difficult. There's no machine, just the glucometer. Do random blood glucose or fasting as your routine investigation. I'll be surprised what they're going to pick. Random. Even if he's saying that he has wound on the do not blood sugar. Please. So they can come in with the classical symptom of polyuria, polydipsia, weight loss, as you know, excess glucose, increase osmolality, drags water, start pissing anyhow. Type 1 are usually lean, like we learned before, and type 2 are overweight. But now we have slim type 2, we have overweight type 1. So things are not just the way they are. It usually has a short onset, yes. Type 2 usually insidious. Insidious in the sense that by the time the type 2 is presenting to you with symptom, 50% of the pancreas has gone. You understand? By the time it's coming, more than 50%. So an infection that brings insulin resistance, you're going to expect the pancreas to bring enough insulin to overcome it, will not be enough again. Next thing, what do you see? Patient coming down. Come on. You saw what happened here. Sister, please, I'm not accepting this thing. So you can have complications can come in. They can produce complications. So from that our discussion, that person, is it diabetic? No, it's not. So what do you do? Like say it depends. It depends, exactly. It depends. So what do you do? Like you said, you see in diagnosis what you're going to do. I don't know. People are just jump starting me now. What do you So what other investigation can you do for this patient? Full blood count, abdominal ultrasound, liver function, all of the above. What's the target BP? 150, 90, 140. This one is not cardiology one, this one is endocrinology one. It depends. What other possible complication can she have? So now, how to diagnose diabetes? Blood glucose, you check for fasting blood plasma glucose, 2 hours, random blood sugar, can do an OGTT depending. So now, when a patient comes to you with a fasting blood sugar above 7 millimoles per liter, without symptoms, what you do is to ask the patient to repeat the fasting blood sugar again. But now there's a caveat. When a patient comes to you with iron blood sugar of 18 millimoles per liter without symptom, please, no need to repeat. Start treatment immediately. You get? But when someone comes, no symptoms, 9 millimoles per liter is okay. Can I reach here? So it's okay, and there's no problem. What you do is just simply tell the patient, let me see you, depending on your own schedule. Some say 1 week, some say 2 weeks, some say 2 days, depending on your own discretion. Patient comes, you repeat, and it's still above 7, that patient is diabetic. Now, the next question is, you take your history. You have family history of diabetes, that gives you an inkling to what you are dealing with. Are you on any drug? Like I talked about, those risk factors and different types. Do you have any condition, any adrenal issue, any growth hormone problem, any phlebotomy? These are things you ask for these patients. After that, the next thing you try to find out, because probably it's a type 2, most of these patients have complications before presentation. So you take it system by system. Start with the nervous system. Do you have anything like smoke covering your eye? You tell you yes. It's very simple. The hyperglycemia is going to stain the lens, distort the shape, and now cause refractory error. Next thing, any history of chest pain, right into the upper jaw, left arm, associated with breathlessness, and feeling of impending doom. I like when cardiologists say this thing, feeling of impending doom. This is a complication you can have in the heart. At the same time, ask about urine production, early morning facial puffiness. They're giving me time. I want to just bring everything together. Early morning facial puffiness and everything. Is it there? Is a complication of CKD. Now, another important one is peripheral artery disease. You ask the patient, do you feel calf pain while walking? that is relieved when you stop. But because the solar muscle will pumping the blood, if there's PAD there, it's giving the patient pain. Now, also the history of burning sensations on the feet. Now, this was very important because most times we doctors miss these things. Please, if you have a diabetic male patient, do not forget to ask about erectile dysfunction. It's very, very important. Why I'm saying that, you can be correcting DKA, he wakes up, clear and awake, you do everything, you don't address his issue, he will not accept your treatment. He will call you, doctor, please, I have a problem. DKA is not a problem. It's out of DKA. It's not a problem now that this thing is not working. Please don't take it with a pinch of salt. It's a very serious issue, most especially for male patients. No, just for male patients, you understand? So that, first of all, they'll have confidence in you and improve quality of life for them. Please note these things. So, having made the diagnosis, this is WHO, ADA, non-diabetic. That what we call non-diabetic hyperglycemia. All those pre-diabetes, before you make the diagnosis, that's what you call non-diabetic hyperglycemia. Now, other investigations you must do in managing diabetic patients is fasting lipid profile, because, like you said, it's a metabolic condition that causes problem with protein and lipids. It causes lipid breakdown, having high cholesterol in the system, which is also a prerequisite for atherosclerosis and cardiac injuries. Must do an ECG in these patients. That's where I'm aligning with cardiologists now. Must do an ECG because most patients can have neuropathy and have what you call silent MI. They might not have pain like the memory present. Meanwhile, they have AT elevation or increased cardiac enzymes. Electrolytes, urine and creatinine, that's for kidney function test. After taking the history, the analysis is important. You check for the protein, check for ketones. This guides you in managing the patient, most especially if it's acute complications. Microalbuminuria is also helpful. Urine testing, yeah. Blood glucose, glycated hemoglobin is important too. It checks within 2 to 3 months. Lifestyle of red blood cell. Now, if you're in a hurry to make a diagnosis, you can do fructosamine test. 2 to 3 weeks. Can also give you that. Now, complications can be acute, chronic. You know the acute DKA, HHS, lactic acidosis. Then for the chronic, you have the diabetic. Sorry, for the chronic, we have the vascular, neurologic, then skin, eye, bones, and related. Microvascular, these are things you know before. Peripheral neuropathy is also there. Skin infection, and have diabetic foot syndrome, cataract, glaucoma. It's just a barrage. But these things are very preventable. Very, very, very preventable with good glucose control and treatment. So, all this is said, 40-year-old businessman who was recently diagnosed diabetic, 19, say pain while walking. You can see. Now this patient is talking about pain while walking. You know what I'm talking about now, right? Diabetic complication. Blurring of vision, you have seen it. Sensation on the feet, these are complications the patient can come with, and you need to address them one after the other. So, investigations, normal UCR, doing fasting lipid profile. So, you have to address the issue one after the other. Now, in treatment, the aim of treatment is to alleviate symptoms, blood glucose control, prevent, delay, or minimize complication. This is very important because most of these complications, when it occurs, it's very difficult to reverse, but it can be prevented. Morbidity and mortality. Now, the target we have is fasting plasma glucose of 6 millimoles per liter, postprandial 7, HbA1c less than 7. Lipid profile, Novartis, I beg to disagree with you. just diabetes. There's no other comorbidities you have. Triglyceride less than 150. LDL cholesterol less than 100 is okay for us. Cholesterol less than 150. Then HDL greater than 40. So if you have other comorbidities, hypertension, cardiac failure, everything, it's not targeting 70, please. Like you said. BP less than 130, 80 is very okay. You lose weight, waist circumference, and everything. So education, like Prof said, education is the main thing. If you don't educate these people, that Babalawo in the village will take your work from you. I'm telling you, that herbalist is going to convince the patient that you don't know what you are doing. It has happened in different locations and it's still happening. Even churches too. I don't have anything against churches, but the problem is patients stop taking their drugs, and when they become comatose, they don't take them back to the church. They bring them back to hospital. That's my problem. So, if you don't educate these people, calm down. There's injury time, extra time. Yeah. There's VR, yeah, it was captured. So, if you don't educate this patient, it's a problem. Most especially diabetic neuropathy. The patient will tell you that he has a problem with his brother, uncle in the village. He went to the farm, that he matched something. He cannot convince him more. That he matched something. Or he had an argument, someone now sent him diabetes, so many things you can imagine. So you need to dissuade all such beliefs. Because if you don't educate these people, they will not take their drug. Such beliefs, you need to dissuade them and encourage them at the same time to understand that these things are manageable, not treatable. They are manageable. Patients can live long if you take your drugs and avoid what you're supposed to avoid. Food care is very important for this patient. Lifestyle adjustment, very important. So, lifestyle measures include 30 minutes walk. Please avoid carrying of weight. There's no Olympics. Just walk, come back. You can do swimming, is okay. Jogging, bicycle riding. Then dietary modification is very, very important. Refined sugar should be not reduced, should be removed entirely. Removed entirely. Understand? Please. Carbohydrates, you should go down. Fiber should increase. Protein, 10 to 20%. Now, saturated fats, they said polyunsaturated is the best. Canola oil. The problem is, where do we get it? The best oil now is olive oil. That is the whole, no, cholesterol free, tried and tested. But now the problem in Nigeria, olive oil is used for prayers, not for. Okay. It's true now. I see patients every time now. Say no, doctor, please don't go there. I spray olive oil in my house for the Holy Spirit to come. I want me to start cooking with it. How will God feel? You know, that things you hear, you don't understand. But my take on it is that it's expensive though, for you to cook food with it. But that religious belief is still a problem. You can use canola oil if you can get. Salt intake is low. Discourage alcohol intake. Weight loss programs should be encouraged very well. Now, you have so many algorithms, like Prof said. So many, if you go everywhere, you have so many treatment patterns. I have like 5 from ACA, from ADA, sorry, from ACE. But let's keep it as simple as possible because these patients will come to you first. Now, the monotherapy is usually the first thing we start with. And practically, sensitizers always work best. That is, metformin by sensitizers are drugs that improve insulin activity. You understand? Before you start giving insulin secretagogues. Sensitizers are always good. Metformin, you can give metformin to a patient. That's always use 500, 1 gram, 500, 1 gram. Maximum dose does not change much. But if you are scared, give you 500. But me, I know you require 1,000 in some few months. So why are you waiting for? I want to let us start the 1,000 immediately. So you can do GLP-1 receptor agonists. These are called incretins, new generation anti-diabetics in form of exenatide, semaglutide, DPP-4 inhibitors. It's also an incretin. So thiazidinones not commonly first. Sulfonylureas are not commonly first. So, but now their target is HbA1c of less than 7.5. That's your target. So you can increase it. It's clear now. So you can increase it after 3 months. That is when you're repeating the HbA1c. Unfortunately, you don't have to wait for 3 months because it's easier to do their fasting blood glucose to check patient constantly before the HbA1c, depending on patient you are seeing. Some can afford HbA1c, some can afford fasting blood sugar. So you have to prioritize their patient. So if you don't achieve control, you move to dual therapy. In dual therapy, you can add GLP-1 receptor agonists. You can have SGL2, that's sodium glucose receptor inhibitors. Now, this drug used to be diabetic drug. I don't know how cardiologists went to go and put it in their criteria for anti-failure. I wasn't surprised. We are dragging this thing, but sorry, Prof, I have to say this one. So, you can add it with the metformin. You can add your DPP-4. You can add your sulfonylurea. Those bromocriptine are extreme drugs. You know, these are white extreme drugs. Yeah, they're not drugs, but not common in Nigeria. Now, I have an input. Sulfonylureas, you always advocate, or people always use dianyl. As glycemic now. Dianyl. Now, glycemic is far better than dianyl because it binds to the receptor that stimulates hormone secretion in the pancreas 9 times faster than the glycemic. And at the same time, it dissociates 9 times faster than glycemic. So now, the advantage is the patient will not have the pancreas overflogged. Because when they overflog the pancreas, the insulin there gets finished. Now when patient that has type 2 now goes to absolute insulin deficiency. So we are discouraging use of glycemic, please. If you have it in mind, please delete it. Unlearn it. I have glycemic idea. That one is safer. Another thing, you don't have to take glycemic to 4 milligram. I've seen 4 milligram AM, 2 milligram PM. You don't have to. We have a wide barrage of drugs to use. And don't forget, insulin is also used for treating diabetic patients. So with this drug therapy, monitor the patient, expect improvement. If it's not improving, throw in another one. At this point, GLP-1 is usually the best to give. But due to availability of all these drugs now, most times patients even start with Gavusmet. That's what they give. They afford Gavusmet. Now, this Gavusmet is a combination of DPP-4 and metformin. Now you have jumped from this 1, 2 to 3. You understand? But there's a problem. These things are not sacrosanct. It is patient specific or individualized into a patient. If a patient can afford semaglutide, here, 1 vial is 300,000 naira. What are you waiting for? Give the patient to be okay. But you cannot go and give a patient drug that's 300,000 or 150 for 1 pen of 4 injections or 5 injections. You're not going to sell his land. Does not make sense. But if you have the money, that's why you want to profile a patient. Like Dr. Seko said, I came from the US. I told this woman, this one they gave you is free. Oh. Say, no, 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 no. I was in Harvard. I used exenatide. I said, no problem. Madam, we have alternative. You're meeting me. I'm the consultant. We have alternatives that also give your blood glucose control. She said, no. I said, okay. I said, no, exenatide he came with. After 3 months, I now sent her where to go and buy. She now called me, doctor, wait. You didn't tell me it was this. No, madam, no be English. Oh. No, be English. You must take that drug. Oh. We were arguing, they're telling me, no, I came from Harvard. Yeah, no, you came from Harvard, no problem. You have the money, Abby. You know, you don't know one foundation paid for it and they give everybody free. And he came here, he want to use it. H medics, go and let's tell how much it be. So after everything, I had to come back to Nigeria level and give her what we have. And she's okay. Main thing is outcome. You understand? So when they have tried all these three and nothing, please always think of insulin. But the problem of insulin in Nigeria is insulin is the end of diabetic disease. They'll believe you have your insulin, you're already dead. So the conviction is so difficult. You tell somebody, say no. So the father used insulin and died. That the uncle used insulin and died. These are you keep on hearing. But now this person is on high doses of everything, 6 milligrams of this pio, 30, 45. This thing cannot work again. There's no way it can work. I always use a practical example for my patients. This orange theory. You buy an orange. You peel the orange, right? You cut the orange now. If you press the first one, water will come out. Second one, water will come out. Sorry, oranges will come out rather, but not as much as the first one. By the third, fourth, fifth, nothing is coming out again. If you like, use this thing and press, nothing will come out. That is what happens to the pancreas. By the time you overflog and flog, you see, when you increase that 4 to 6, first 2 weeks is okay. By third week again, you start seeing 11, 8. I'll come back again. No need wasting all these drugs. What you do, give insulin. If you can take the orange once, keep it in the fridge, buy orange juice, that one will last long for you now. That's just it. But them to start insulin is a problem, big problem. So what I employed, or what I normally do is, I'll tell you, let's do 2 weeks trial. After 2 weeks, that patient will call you on the phone, doctor, this drug is very good though. No more problem. Most especially for the men that have ED. As they will not call you back again, they'll continue the insulin. So, insulin, like I said, people are scared of insulin. It's a very good drug. There's no problem. The only thing, you know how to titrate it. And no signs of hypoglycemia when it comes. And another thing is this. If you have a hospital, you have nurses that are giving insulin, please, our nurses are here. I keep on telling them, if you want to give a patient insulin, ask the patient, show me your food. Not, do you have food? There are two different things. Do you have food is, my wife is on the way. You go and bring food. That wife now probably has gone to market. From market, you're going home to go and cook and bring the food in 3 hours' time. The nurse or the caregiver will simply put the insulin, give the patient, give the patient insulin, and eventually you go to sleep, patient will sleep. As they are waiting for the distance to come, next thing, the wife will now come. His husband is sleeping. Don't disturb him. They will keep the food. Next 6 hours. Won't you eat? My brother, it becomes a problem. 50% will not cure that one at that point. Unless God intervenes. Look, I'm a staff here. Do you know that? So with that, please, normally all we add is the long-acting insulin. Makes it easier for the patients, depending on the patient's requirement. Or most type 2, they do well on long-acting. That's what I even advocate. Because, if you're convincing somebody to take insulin, you now say, go and bring syringe and be pulling it every day. It makes it difficult. Simple thing, get a Lantus pen, give the patient, tell her, Oga, just once a day before night food. The following morning, he will see the outcome. Because their patient becomes worried when that blood glucose is 10, 12, 14, 15, because he has been told that this one can kill him. So by the time you use that Lantus pen with drug I've adjusted for him, and in the morning he sees 7, you keep quiet. Following day 6.5, the other one 5. What are you saying again? Doctor, you are the best doctor. I'm telling you. So please, we encourage him use of pen. How to calculate it is 0.3, depending on patient's weight, per kg, as for long acting. But now, generally, you have different insulin regimens. I won't go much into it, but one wants to use is what we call the basal bolus, where you give short acting before breakfast, short acting before lunch, short acting before dinner. Now we now give long acting in the night. We call it basal bolus. It tries to mimic normal insulin secretion in the body. So in calculating such ones, is here. You see the slide now. What you just do, 0.3 units per kg times the patient's weight. Now, if the patient is 100, what's going to be is 30 international units. Now, for that basal bolus, what you're supposed to do is to divide it into 2, give one as the bolus, Lantus, then the remaining one, you try to titrate it according to the patient's meal. The problem we have most times is, say, give the patient 10 international units TDS. Now, in the morning, he eats 2 slices of bread and any type of pap that he likes. In the afternoon, he eats wheat and bitter leaf soup. In the night, he eats beans. Now, insulin requirements cannot be the same. For morning, afternoon, and night, it can never be the same. So, that remaining half is what you do to titrate. If you are giving the patient, let's say for instance, 15. You give the patient 6 in the morning, 10 in the afternoon because of kind of food he eats, and 6 in the night. That's how to do these things. But unfortunately, it's very difficult to avoid severe hypoglycemia. You don't give patients short acting to go home. Actually, they can't go home with it though. But in Nigeria, our level of negligence and I don't know is very high. Someone can now give himself short acting and want to go and bring food. You understand? And the action of these things are so short that you might not get to that kitchen. And if there's nobody in the house, it's over. You understand? So we advise use of long acting with your oral hypoglycemic agent. I don't know, I have to stop here. These people are on my neck, so they won't pursue me from where I work. Thank you very much. I hope you enjoyed the lecture. They should have questions now. So, questions, we can expatiate on the question. Next thing is not lunch. No. Questions. Thank you, my brother. Who has the mic now?
Thank you so very much for this very wonderful lecture.
Thank you.
My question is on semaglutide. What's the correct management procedure for a patient who has been on semaglutide, apparently doing well, and all of a sudden, for 2 days consecutively, the fasting blood sugar is 80 millimoles per liter?
Okay.
What would you do? Thank you.
Sorry, fasting is what?
It's fasting blood sugar.
Yeah, when
18, 18, yes.
18, okay.
18 millimoles, yeah.
Okay.
Thank you.
Now the question first of all is the patient on semaglutide alone? No.
For that, yes. But
Alone.
not necessarily alone. Other
let me know.
comorbidities.
I have to answer this question with what you have, so that I can just go
Okay.
and guess.
Okay.
It's on what is it on metformin,
No, just okay. For diabetes, just semaglutide.
semaglutide.
Yes, please.
Okay. So, and it's 18. Projector. From that thing we said, the first line, the monotherapy, semaglutide was one of them. Yeah. Monotherapy here is one of them. You are choosing that as a monotherapy. If you don't have control, what you do is go to dual therapy. You understand? But for what we have here, you know the way this semaglutide works. It's an incretin, and it only works when you eat. You understand? It had different mechanism of action. People actually misconstrue it that it makes you lose weight. Now that weight loss is a few percentage. It makes you lose weight. Why? What it does is to reduce satiety, reduce what do you call it, hunger, this thing. Then increases satiety, decreases glucagon release, and then causes this gastric, this thing, reduce gastric outlet. So now, with that, the body mops up what you have, the glucose you have. Use alternative source of income, not income, sorry, source of source of glucose. Don't blame me now, people man. Now. So, only source of glucose, you understand? Technically, a patient might have some weight reduction, but it's not for weight reduction. You get. So now, what you do is to introduce a second. It's independent. Like I said, you have to profile your patient. First, can he maintain semaglutide? Yes, and then if you can, do other things. Give him back now.
Thank you.
Yeah.
I asked this against the backdrop of the possibility. I don't know if I'm right. Is it possible that could be a side effect of the semaglutide?
High blood glucose.
Yes, please.
No. The work of it to reduce blood glucose. Now, cannot be, like I said, the way it works is not from pancreas. So, understand? It works through what you call the eye cells on the GI, incretins. Understand? When you now, so this DPP4 inhibitors is what clears the incretins in the system. You get the point? So now, when you give them stagliptin, linagliptin, what it does is to enhance the half-life of incretins in the system. But now, this other one is a receptor agonist that now enhances the effect. The DPP4 does not affect it, but it affects the normal body insulin. You get how it works now. So it cannot be a side effect in the sense that you expect it to work. That's why it's good is it's only when glucose enters the GI, those eye cells release incretins. You understand? That's the way it works. That's why it's very, very expensive and different. So, more questions now, more questions. How do we calculate of insulin? I said it. I said it before. Okay. What's that? Okay. How do you calculate insulin dose in hyperglycemic emergencies? So another topic also. In emergencies, you have acute emergencies. You have the DKA, IHHS commonly. Now, these two conditions are approached differently. One needs insulin. One does not need much insulin. DKA needs insulin, definitely, because if you don't give insulin, the lipids will keep on breaking down. The homosensitive lipases will not stop working, and ketone bodies will fill the system, and the patient can have brain issues, and the patient can die from that. That ketone is very bad. So you give insulin in those patients to make sure that you inhibit the ketones. And unfortunately, in Nigeria, we only check for urinary ketones. That is acetotic acid. We don't check for the main one, which is the butyric acid. But you use your urinalysis to check. But if you have no ketone in urine, please don't be deceived. There's no ketone because the nitroprusside in our stick only detects acetoacetic acid. More butyric acid, if it's there, it cannot pick it. So now calculating insulin, this patient, like I said, is 0.1 natural units per kg as the patient comes. Now you start your insulin, hourly insulin. If you have infusion pump, it's good. If you don't have infusion pump, you can create your own using normal saline. That normal saline, 500 ml of normal saline, you can give, put 30, depending on what you want to achieve. If you want to achieve 10 units in 1 hour, let's say for instance, patient weight is 60 kg. You want to give, if you have a competent health worker with you, you can give, you want to give 0.1 unit per kg, that is 6 international units every hour. Monitor the patient. But now, in DK, like I said, you want more of insulin, you can titrate it if you don't have your insulin pump using normal saline bag. 500 mils, you put 30 units inside 500 mils. Make sure it's mixed well. For every 100 mils entering the system, we have 6 units in it. You understand? You know, in Nigeria, we create things for ourselves. Our patients, they do well. So now, for every 100 mils, you have 6 units entering the system. So it's like a continuous process. You understand? And with that, you're able to achieve glucose control, bring it down, change your subcute, treat precipitating whatever is infection, anything, you treat it. Now cancel the patient. But for HHS, if you give your glucose, the main thing they want more is fluid because there's hyposmolarity in this patient. You can use your anion gap osmolarity to calculate. With that, don't forget, please, always give anticoagulants in HHS. HHS is a procoagulant condition. Patient can be okay. Tomorrow you have pulmonary embolism and die. You have a stroke. Please, always give. Now, in DKA, if you have an obese patient, please always give. If you have a patient that has an MI, always give. If you have a patient that they brought from village, know that person had at least 2 weeks in the house before they bring him out. Anybody for an uncle, one uncle or one brother, around come 2 weeks, always give. Now, if you have a rich patient that can afford it, no harm, give. Please. So with that, I want to assure you, like Chief said, patient will wake up and patient will do well. And diabetes is easy peasy. You understand? There's no difficulty in this thing. You understand? Apart from the residency.
My question is, please, is there any special dose of administration of this insulin in gravid women? If yes, then I want to know, please.
You have to comment.
Gravid women, pregnant women, yes.
I thought I put. Sorry. Are you able to order me this thing? We are family now. We are family. Sorry, please, just before we go, I have 2 cases here. Now, the first one is 37-year-old teacher present to the gynae emergency at 14 weeks. Like I said, 14 weeks. RPS of 13 millimoles per liter. She had 2 previous pregnancies carried to term. 1, which other history might you be interested in making a diagnosis? As 1, what is your diagnosis? Now, second one, 42-year-old businesswoman present to the clinic at gestational age of 27 weeks with fasting blood sugar of 5.6. There's a previous history of macrosomic babies in the past 2 pregnancies. What is your diagnosis? What is the reason? Before we go, can someone just take the first one? Give us the reason. Are you not enjoying this thing? Calm down now. Someone, no, it's not. No, there's nobody's marking anybody here, so you just go through it together. Give that guy that asked me a question. Give him. That's what they do for residency. You don't ask, collect. Give him microphone. So what do you feel? This first one, do you feel this patient? What do you feel is wrong with the patient?
Um,
14 weeks of gestation, RPS 13 millimoles per liter. You come again, madam, come back in 1 week time. It's 14. Let me complete it for you.
okay.
So what do you feel is wrong with that?
Yes. Based on what you previously said, you said when the glucose level is more than 10 millimole per liter, then you consider that patient as diabetic patient. Then you can undergo.
My brother, are you inside this hall?
Yes.
You dey see you. I never come up for stage. Yeah. Please. This is my name, Prof. You dey see. I didn't say that, please. I said for diabetes, more than 7 fasting in 2 different occasions is diabetes without symptoms. But you can do an RBS and see 18. You don't send the person home, do analysis immediately and start your management. But it's okay, no problem. You try. So you think it's not diabetes, right?
No, it's not like that.
You don't. No, you think now, right? No problem. Any other? Who are the women now? Why the men always they show working for
He
here?
thinks it's diabetes now.
Is it?
I think he thinks it's diabetes.
Who's talking now? Who they talk now? Okay, sorry.
He thinks it's diabetes. That's what he said.
Do you think it's diabetes? Okay, do you think it's gestational diabetes?
Yes, it should.
Gestational diabetes, right?
Yes.
14 weeks. Okay, any other counter?
My question is
Madam, we get question
sorry.
with the answer here. With the answer question. So let's move. Operator. You don't come on me. Okay.
Okay, for the another, okay, for which other history? I'll
Okay.
be interested in maybe history of stillbirth, previous stillbirth, or history of macrosomia.
Say he has carried to term without any complication. That's the idea now. Make I turn your head small. So now the patient is. Ask the patient, Madam, are you non-diabetic before? Now let me take second one. 4 point. Short. Let me waste time. Gestational diabetes is diagnosed at what month? So at what week? 24 to 28 weeks. Anything before that is pre-gestational. So now this woman came in with 13 at 14 weeks. That time this thing has not even come up safe. So most likely it's pre-gestational. And at the same time, I gave you there's no problem with the last 2 pregnancies, which is not possible for diabetic. So now this one now. This is 27 weeks. 5.6. Macrosomic babies in the plastic. Do you think it's gestational diabetes? Why? I'm not asking you. Why? I said 5.6. So please. I said 5.6. And it's 27 weeks. At that point, the human personal lactogen is at its peak. The hormones are changing and causing resistance. So what do you think? Is it gestational? You don't quiet. Eh?
Yes.
Why is it gestational?
Because of the history of macrosomic babies. Then the gestational age too.
5.6 is it diagnostic or that?
The gestational age at
Calm down now.
presentation.
The fasting is 5.6. 5.6. Brother, before they beat me for here, let's go to how to make diagnosis. Now, according to the Association of Diabetic and Pregnant Study Group, they said at least one value of fasting greater than 5.1, 1 hour greater than 10, and 2 hours greater than 8.5. Now, that 5.6 I put there to be confusing. Because 5.6 is not a normal blood glucose. But any pregnant woman with greater than 5.1 is gestational diabetes. At 24 weeks is gestational diabetes. Do you hear what I said? Any pregnant woman that has 5.3 above, 5 above in this thing, that 24 to 28 weeks and above is gestational diabetes. I think I'll sorry before insulin is used in managing gestational diabetes. Now, first of all, please, before I say insulin, all treatment is lifestyle modification. That's the first thing. We call it MNT. Nutritional therapy. That's the first thing. Ask patients to exercise, diet modification. Now, look at it. Lifestyle modification, diet, physical activity to make glycemic control. Now start coming down. Now they have a caveat there. Patients can be given metformin and Libride, that's sulfonylureas, but it is not licensed. Patients can be given metformin and glyburide, but it is not licensed. It might be on your own case that patient will not have one big ear. Say, are you causing? So the best thing we know is use your insulin as treatment. The way we calculated it, the best is long acting for them. If it's not, you can use premix, what you call mixed-tat or 70-tat. You understand? But if there's need for you to use metformin, you can use. But the word is, it is not licensed. Thank you very much. I hope you had a wonderful time.